Well, good evening, everyone. I wanted to welcome everyone to tonight's webinar. I'm your host, Dr. Lauren Levine. We've got a great turnout this evening. We had over 1,000 people that were registered for the webinar. I see a lot of people are here. A lot of people are logging in even as I speak. I'm only going to talk for a couple of minutes or so. I want to make sure that Dr. Nazarian can speak for as long as he needs. We also want to make sure that you get a chance to ask questions. Now, a number of you actually asked some questions beforehand, which we will get to those questions. That was kind of something new that we tried here. For those of you who maybe it's been a while since you've been on a webinar, or maybe this is your first time, the format's pretty easy. On your screen, you have a GoToWebinar control panel. You have a little place there where you can type in your questions. We don't typically get to the questions until the end, and we try to get them in the order. I will be upfront and tell you that if this is like our typical webinars with him, where he talks for 45 to 55 minutes, we are going to have a short presentation from Kurt, our sponsor this evening. Usually only gives us about 20 to 25 minutes for questions, and we oftentimes have well over 100 questions. We're not going to get to every question. We'll do our best. I get to see all the questions. I can be able to see which ones I can consolidate or which are the common themes. I'm going to do my best to try to get to as many as we possibly can. If we don't get to your question, I apologize, but we're trying to get to as many as we can. This webinar, like all webinars, is being recorded. If for some reason you cannot stay in towards the end, don't worry about it. At some point within the next day or two, we will send out a link that has that you can download the entire audio and video recording. GoldenDent, which is our sponsor for this evening, has also graciously agreed to provide continuing education credits. Every time I do one of these webinars, I'll get emails for about a day or two afterwards saying, how do I get the CE and how come I haven't gotten it yet? When we have 1,000 people on the webinar, it takes a while. It's not like you can just log in for 2 minutes and that means you get the CE, or you come on for the last 5 minutes and you get CE. AGD PACE has certain criteria. I think you have to be here for at least 80% or 90% or something of the webinar. So we have to go through all that. The CE will go out, but a lot of times it does take a couple of weeks. So please be patient about that. Speaking of GoldenDent, I just wanted to thank them for their ongoing sponsorship of these webinars. We've done a series of webinars with them for the last number of years. If you are a dentist, if you're in the dental field, you know about GoldenDent, and they have really committed to ongoing dental education. These webinars are a perfect example of that. If you've ever seen them at any of the trade shows, they have a great presence there. They've got clinicians in the booth. It's really something that I enjoy doing with them. At the end of Ara's presentation, Kurt Lawler from GoldenDent will come on at the end. He typically is going to make some type of special offering for you, talk a little bit about some of the educational opportunities they have as well. So please pay attention for him, because normally that offer is good for a relatively short period of time, usually only a day or two. So it's something you're going to want to take advantage of. With that out of the way, I wanted to introduce our special speaker for this evening. That's Dr. Ara Nazarian. He's been here many times in the past. He maintains a private practice in Troy, Michigan. He emphasizes comprehensive and restorative care. He's a diplomat of the ICOI. His articles have been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted lectures and hands-on workshops on aesthetic materials and implants all throughout this country, Europe, Asia. He's on the faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, and immediate dentures. He also founded Ascend Dental Academy, which teaches all aspects of dental implants. So, Ara, without further ado, I wanted to turn the mic over to you. We're looking forward, as always, to your presentation.
Thank you so much, Dr. Levine. I'm very honored to be here again. This evening, we'll be talking about the surgical protocols for full mouth extractions, leveling, and grafting, but most importantly, in one appointment. Well, this is how patients are presenting to the practice, whether it's advanced periodontal disease, gross decay, severe bruxism. We see a variety of different patients presenting to practices all across America with issues that are requiring full mouth extractions. The question is, what is your recommended treatment for these things? Well, there's available options to propose to our patients. And so when patients present with these debilitating cases or conditions and they need full mouth extractions, we have a variety of different options to propose. The first is upper and lower complete dentures. Second, we'll offer dentures but have the lower overdenture on small diameter implants or possibly on traditional implants. Then we can offer overdentures in the upper arch and fixed lower bridges in the lower arch. And if somebody chooses to go with fixed over fixed, we can do that, avoiding any type of sinus augmentation by angling the upper implants if necessary. And then finally, we have the full Cadillac type of treatment, which is implants over implants with fixed prosthetics, but we're getting second molar to second molar. So in the upper arch, we have 2 to 15. In the lower, we have 18 to 31. Usually these are parallel placed or axially placed implants. And if there's any augmentation that's necessary, like sinus augmentation, then we're doing that as well. Here we see an example of a denture makeover. So not all patients are going to accept dental implant therapy, and removing the infection and the source of infection, which are the teeth that have severely decayed or that are severely infected, is the start. And so we actually can do makeovers with removable dentistry. However, our ideal goal is to provide dental implant therapy if possible. So this evening, we'll talk about the basics, which is extraction, leveling, grafting, and the delivery of immediate dentures, and then also showing examples of utilizing implants for overdenture treatment. So let's take a look at the first case: extractions, leveling, grafting, followed by immediate dentures. This patient presented to my practice saying the following: I hate my smile. I have a lot of teeth that are broken down to the gum line, so I know I need several teeth extracted. I'm very scared about getting this dental treatment completed. I want to be able to smile again without any embarrassment. I want straight, white teeth that don't hurt all the time. Upon closer examination, we can see the severe decay not only in the upper arch, but also in the lower arch. In fact, underneath the anterior bridge, we found that there was further decay. Well, when a patient comes in with this type of chief complaint, the first thing we do is give them a tour of the office once we've welcomed them in. And so our new patient protocol is to start with that, not to have them fill out paperwork, but in fact to welcome them into the office and give them a tour of the office. Within the office, we'll show there's a variety of different diplomas and plaques and articles that are posted on the wall. So we call this the Hall of Fame. And so we illustrate to the patient the importance of continuing education. The staff indicates the variety of different lectures that I've given to other dentists and the different diplomas that I've gotten, for example, from the International Congress of Oral Implantology, to strive to these patients that education is important and to stay on top of the leading edge is very important. So these are just some of the examples of when we're giving the tour. We'll also show them the photo room, and in the photo room we have a variety of before and after photos that show actual patient cases, whether they're denture or overdenture or full fixed implant reconstructions. Patients get a chance to look at the photo room and see, wow, this Dr. Nazarian is doing quite a bit of dentistry, and it's his actual patients. These are not photos that are purchased in a book. We also will show them the sterilization, because sterilization is very important, and patients have a concern. They want to know that everything is clean, that not only does the office look clean and smell clean, but that the instruments are sterilized. At this point, usually one of the staff members will see if they need anything, if they'd like a refreshment, a water, a soda, or a coffee, and return the patient back to the lobby area to fill out the paperwork and fill out any questionnaires if the patient is interested in changing their smile or if they're interested in IV sedation. So the new patient protocol is really a process. Patients, when they come into our office, are treated a little differently than what they're used to experiencing in a medical or dental office. Lastly, once they filled out the paperwork and the staff members are ready to put it into the computer and they're inputting all this information, we'll give them a before and after book to look at, which shows further cases of what I've completed over the years, so that these patients see that they're not alone and that I've restored several hundred smiles, and so they can relate to these patients. And so at this point, it's our goal to bring them back and educate them step by step. So once they've filled out the paperwork and they've gone through the tour, our goal is to collect the data. And collecting the data, we've already done the questionnaire. The next point is to acquire the radiographs. So we try to get all our FMX and Panorex radiographs, and we're obviously going to also take a CBCT. We're going to find any clinical concerns that we may have, but also in addition to all these things that dentists are already doing in their office, we'll take photos. We usually take some extraoral photos as well as intraoral photos, and I'll share those with you in just a moment. If any models are necessary, we'll acquire those, whether they're with impressions or digitally. I think it's imperative to acquire these types of models so that you can further articulate these and see if there's any discrepancy in occlusal harmony of any sort. And again, as we mentioned, if we're doing several extractions followed by implants, we definitely want to acquire a CBCT. This is the standard 4 series of photos that my staff gets when a new patient presents to our practice. And you can quickly see that we have the extraoral smile, we have the intraoral retracted frontal view, and then we have the occlusal aspect of the maxillary and the mandibular arches. This is Bluetooth right to the flat monitor in the operatory. So as soon as the assistants acquire these images, it is portrayed on the flat screen TV in the room. Many times patients will look at this and go, are these my teeth? Because they've never really seen this perspective, especially from the occlusal aspect of their teeth. It's very important in the whole case acceptance process. At this point, we'll do our clinical examination and identify any caries, crazed lines or cracks, broken teeth or broken restorations, any bleeding on probing or any issues with their gums or inflammation, any mobility of teeth or areas of wear. And if we're looking at implants, we definitely want to check the areas of available bone, areas that are edentulous or have they been edentulous for several years, areas of keratinized and attached gingiva, and then if they do have a prosthesis, are they wearing it, and the fit of the prosthesis. So if we take a closer look, we can clearly identify the areas of decay. Clinically, we can see that not only are there cervical caries, but there are also areas of wear and tear in addition. We can see that the decay is so extensive in some areas that the crowns or existing crowns have broken off at the gum line. So this patient definitely has a high caries rate. So to try to restore this patient to health, long-term prognosis, trying to salvage these teeth may not be very successful. As we mentioned, our goal is to acquire a CBCT. The CareStream 8100 that I have in my practice not only acquires 2D, but also 3D images. The beauty is it can go as small as 4x4 or as large as a 9x8 field of view, so that you can really examine these areas thoroughly. This is just illustrating the 2D image that you can acquire, and then we can also acquire a 3D. But upon radiographic examination, not only can you see the rampant decay in a lot of these teeth, but you can also see the periapical lesions that are evident in a majority of these teeth? Well, when we present the various options, such as denture, overdenture, fixed bridges, we also want to talk about fees. A lot of dentists try to avoid talking about fees, but I think it's important for patients to understand. So a typical example would be a patient presents and we indicate to them that they do need to have these teeth restored, that they're no longer restorable. And so we want to restore them with either removable or fixed. And they here can see from this image of the different price ranges that removable can go anywhere from 4,000 an arch to about 9 to 10,000 an arch. And if we start looking at fixed, we're looking at 25,000. So if we look at the top right corner, the overdenture on the top with 4 implants would be around $10,000 and a fixed would be 25. So if we do the math, we quickly see that the total would be roughly around $35,000. This is so much more effective and efficient than you giving the treatment plan to the assistants or treatment coordinators to put into the computer, and 20 minutes later when they're finally done, try to explain this to the patient. The patient is already out of time or frustrated because it's taken too long. So what I recommend is that you present in bundled fee amounts an idea of the price range that is available for the various amounts or types of treatment. So in this patient's case, she decided to go with the full mouth extractions, followed by just upper and lower immediate dentures, followed by definitive dentures. When we present to these patients, it's imperative that we give different types of payment options. Alpheon Credit is a great third-party payment option for these patients. You get, it's almost like a credit card that they can use within your office. And so I definitely recommend you take a look at Alpheon Credit. It really makes this type of dentistry very affordable. Well, once they've been approved and the money has been wired to the account, we can continue with our records and start treatment planning and setting up the appointment for IV sedation. So the first thing is to get a records appointment. Once the patient has decided on the treatment that she wants, she's going to return for this records appointment, at which time we're going to take further photos, document this, write the instructions to the laboratory, and send the impressions and the bite registration. And this allows the laboratory to have everything that they necessarily need to make the immediate dentures. They have the incisal edge position, they have the midline marked, but most importantly, at this point, she's paying to lock in the surgical IV sedation date. So since she's paid and date has been locked in, we can see that we're ready to evaluate the midline. I think it's very important to indicate to your laboratory where the midline should be. Labs don't appreciate when you just say upper and lower immediate denture, shade B1. They need a little bit more instruction, especially if you're changing the midline or if the teeth that are existing are canted. In this case, they're obviously broken down. So we really need to evaluate the midline and incisal edge and deliver some of these photos to our laboratories so they can make some nice quality and aesthetic looking immediate dentures. We also instruct to the laboratory golden proportion. So for example, if we're going to make the centrals 9 millimeters in length, then we know that the laterals are going to be slightly shorter and follow the golden proportion rule. When setting denture teeth, I like to instruct the laboratory that I like a little bit of a mesial shift when we're looking at the long axis of the teeth so they look more natural. We also will indicate in the photo if there's any canting. So we want to make sure that the incisal edge is parallel with the interpupillary line. So these are just a variety of different things that I'll draw on the photos to indicate to the laboratory how to make an ideal immediate denture. So here we can also indicate where the bite is. We're going to open the bite up a little bit. Here we have the Futar bite from Kettenbach. This sets within about 30 seconds. One important rule that I tell all the dentists that I train at the Ascend Dental Academy and Amplify Dental is that when taking a bite registration, make sure you use retractors. When using retractors, it keeps the cheeks and the lips off of the teeth so that when you dispense the bite registration, it's not moved over or it's not distorted by their cheek movement or anything. And you can actually see when you're dispensing it if they're biting down properly. So I think this is very important to see. So this is the Futar Fast bite registration from Kettenbach. In the upper and lower arches, what we've done is in the past we used to use alginate and the assistants would either have to rush to pour them up or they'd wrap them up with wet paper towel. Now we have a material called Silginat from Kettenbach. This can be poured up days later or hours later and it doesn't distort because it's actually a polyvinyl siloxane, but it's at the cost of alginate. And so we'll send these two impressions of the Silginat along with the bite and photos to the laboratory to instruct them how to make the immediate dentures. So the laboratory will pour these models up, mount them, and at that point they'll use it as a working model for immediate dentures as they slowly start to grind the teeth out. Usually what we like to prefer is a lingualized occlusion in the upper arch that occludes along the central groove of the lower teeth. This way the pressure is not only stabilizing the denture, but it's placed along the ridges of that are remaining after we extract the teeth. So here's a close-up. This is taken from Dr. Carl E. Misch's book, Dental Implant Prosthetics. So the maxillary posterior teeth use an anatomic tooth form for the aesthetics and function, where the mandibular posterior teeth should use more of a flat or non-anatomical tooth form. This way you have the lingualized occlusion going right into the central groove of the lower teeth. The teeth of choice in my practice that not only have strength but aesthetics are the Veneris 2 from Ivoclar Vivadent. The nice thing about this is the lingual aspect of these teeth, or the core material of this is PMMA, and then the incisal facial aspect of this is nanohybrid composite. So when you look at these teeth, they look very, very natural. They don't look like fake denture teeth, and they wear very well. So here you can see the laboratory has fabricated the immediate dentures. We're ready for the day of delivery when we extract these teeth. Here on the day of surgery, I'm anesthetizing the patient. You can see we gown up when we're doing a full arch of extractions. And so this is our starting point. We can see there's several teeth that are infected. So we want to make sure once we remove these teeth that we curette this out very thoroughly before we place any type of grafting material. When looking at teeth, the ideal tooth extraction is defined as the following: the painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals without compromise and no postoperative prosthetic problem is created. I think this is very important to remember when extracting a tooth. Yes, we can all rip a tooth out, but our goal is to create minimal trauma to the investing tissues and to not damage the buccal plate or the surrounding area, and to create something that's going to give us a good prosthetic outcome. Well, the instrument of choice for that is definitely the physics forceps. I've been using the physics forceps now over probably 11 to 12 years now, and actually it works like a modified class 1 lever. In fact, it works so well that it really makes sense once you look at the fulcrum activity of the physics forceps. Well, when we look at this schematic, what makes more sense? We see that obviously the bottle opener makes more sense when we're taking a cap off, and that's a modified class 1 lever. When we look at the example with the hammer and the nail, then obviously that makes more sense as well, because that is a modified class 1 lever. In fact, Archimedes is quoted as saying, Give me a place to stand and a lever long enough, and I will move the world. Well, we're not necessarily moving the world, but our goal is to take teeth out efficiently, effectively, and predictably. And the physics forceps in my practice works very well in order to be able to do this, especially when I'm looking at preserving that bone to place future implants. So let's look at the steps that are involved when using the physics forceps. The first step is to engage the lingual or palatal aspect with the beak. And it's imperative to engage the tooth structure that's solid. So if you find that there's decay on the lingual or palatal aspect, you may have to trench out just a little bit of that portion so that the beak will get onto solid tooth structure. When we say trench, we're trying to get a purchase point onto the tooth. So sometimes we'll trench in between the tooth and the bone just so that we can get the beak in good enough to grab the tooth. Once that's been accomplished, then our goal is to place the bumper as high up into the vestibular area as possible. The greater the distance from the beak, the better the fulcrum. Now, it's imperative that you don't squeeze too hard at this point. Remember, our goal with this type of lever is to rotate the tooth out of the socket, not squeeze this and break the buccal plate. So without squeezing the handles or moving your arm, begin to apply a steady, very slow rotational force in the direction of the bumper. Patiently continue to apply the steady force for about 30 to 40 seconds. This force or creep will continue to build up, allowing time for the periodontal ligament to release and the bone to slowly expand and the tooth to disengage. In fact, over time, an enzyme is released. And this enzyme, as we all know it, is hyaluronidase. And this allows the hydrostatic pressure to build up. And eventually, within 30 to 40 seconds, you notice either an audible pop or that the tooth slightly moves. And usually at this point, we know that it's time to remove the tooth fully from the socket. At this point, usually I'll take a tooth delivery forceps. You can take a 150 forceps if it's an upper or a 151 and further extract it from the tooth. So when we look at the biochemistry of tooth extractions, the physics forceps with its steady, unrelenting trauma to the periodontal ligament quantitatively creates a greater release of the hyaluronidase in a shorter period of time than traditional forces or elevator extractions because the trauma from those techniques is intermittent. Where when we look at the physics forceps, it's more efficient, it's faster, and less traumatic to the alveolar bone. So there's quite a few references to this, and I've personally experienced this over the last 11 years. Well, once the tooth has been extracted, it's important to curette any granulation tissue from the area. So instead of trying to go through a bunch of bagged instruments, I think it's important to have a few of these kits that have everything included in them. And these include an Orban knife, a curette, a bone file, a mucoperiosteal elevator, a bone spoon and plugger, tissue forceps, tissue scissors, needle holder, a scalpel handle, and then obviously a bone dish. And so these are all available from GoldenDent. Here you can see the curette. Now notice these instruments are all blue. They have a titanium nitride coating which maintains their sharpness and increases the strength. So here you can see I'm actually using the curette to just sever the PDL, and then afterwards I'll go ahead and engage with either a separator, a wedge, followed by the physics forceps. So the wedge is the perfect pre-step to your atraumatic extraction process. The sharp, thin tip of the wedge instrument is actually designed so it can be pushed apically easily between the remaining tooth root and the bone using a slight rotational movement. So unlike an elevator that you're elevating the tooth, you're actually going between the bone and the tooth. And because it has an elevator handle, you can actually put a little bit of force and strength into it, unlike some of the peritomes that you've seen. So this actually creates a wedging action between the rigid, hard tooth surface and the bone. Well, we'll follow the wedge with one of the physics forceps. As you can see in this area, we're going to the upper right. So we're using the upper right forceps. As we move to the anterior portion, we'll use the anterior physics forceps. And then as we move to the left side, we'll go to the upper left. In the lower arch, we have lower universal physics forceps that can be used in the whole arch. So here you can see that I'm sequentially going around the arch and efficiently and effectively extracting all the teeth without breaking any buccal plates. Here we can see all the teeth that have been extracted, and you can really see how much decay was actually present in these teeth. They really were non-restorable. Well, a lot of dentists like to stop at that. I like to reflect a bigger flap so that I may remove any of the sharp tines of bone out, whether I'm using a bone file or a bone burr. I think it's important to relieve any of these sharp tines of bone, because even with a soft reline, these patients will complain of these sharp areas of bone. So what I'll do is either A, use one of these burrs. This is a burr kit that I've created for GoldenDent. And so the 3 burrs at the top are used for further removing any granulation tissue. In other words, we're used to degranulate the area. The second burr, which is a carbide burr, is used to trough around roots or to section roots. And then lastly, the pear-shaped burr and the round burr that go in the straight nose cone are used to further level the ridges. So in the first example, we can see how we're using the round diamond to degranulate the sockets. The last thing we want to do is leave granulation tissue in there and then cover it with grafting. So it's important that we remove any granulation tissue that may be stubborn that you can't remove with a curette. So I'll usually follow with this diamond burr. You can see I'm going into the socket. There's a surgical handpiece that we're using, so it's only spraying water, no air. Once we've accomplished that, we'll follow up with a bone file or a bone burr to just remove those sharp tines that are between these sockets that may cause pain areas for this patient. So we want to smooth those out as much as possible. We'll confirm the fit of the immediate denture. And if the immediate denture looks good and we've smoothed the ridges of bone or any undercuts, then we know that we can go back and place grafting. Bone grafting is really the foundation for implant therapy. It's important because you don't want to try to graft after the fact. It's much easier to place socket preservation as compared to trying to go back later and augment the area. So the art of grafting, especially socket preservation, is to preserve the socket at the time of extraction. And we found that if you fail to plan for this, then usually you may not have failure, but you may not have the most ideal ridge to work with. So what the studies have shown that I've seen is that if the buccal wall is more than 2 millimeters in thickness, then you don't always have to graft. That socket will usually fill in. But if it's less than 2 millimeters in thickness, then we found that usually that buccal plate collapses, and now further augmentation procedures may be necessary. I say, why take a chance and preserve the socket every time if you can, especially if you plan on doing implants later on. Well, one way that I explain this is with the DemoDent patient education model, also available from GoldenDent. If you look at the left view where the tooth is removed, it illustrates the importance of socket grafting to fill the void. But this model also shows occlusal and interproximal decay, tartar buildup, recession, failing amalgam restoration with recurrent decay or a crack on the opposite side, and then finally core and crown restoration. What I found is a patient education model always works better than a video, because as you explain it, the patient is paying attention to you and they can visually see what it is you were talking about. Well, what are some of the main reasons for socket grafting? If we take a look, we know there's several. I think the easiest one, as I mentioned earlier, is the fact, number 5, it's much easier to preserve now than to try to create later. And this is important to remember when you take a tooth out. If you place socket preservation material in there, then it's much easier to preserve that ridge as compared to not grafting. It caves in, and now we have to resort to other grafting procedures to build the ridge. So this is something from Clinician's Report in 2010 from Gordon Christensen. I think this was a great report illustrating the importance of socket grafting. Well, what are the different materials that are available? First and foremost, we have what we call a xenograft. Xenograft means it's anything other than human. Usually we see that it's bovine bone. And so one of the most common ones out there is bioos. We also see that there's allografts. Allografts are human bone, and they come in a variety of different sources. It could be either in a putty form, it could be in a particulate, and sometimes they come in gels. And there's a variety of different tissue banks that provide these types of allografts. Alloplasts are synthetic bone materials. Osteogen is an alloplast sort of hybrid because it uses a bovine Achilles tendon, but the actual graft material is synthetic, which is the osteogen. And then lastly, we have autogenous bone. Autogenous bone, the advantage is that it's osteogenic, and it contains osteoblasts and a variety of different cells for potentially faster regeneration. But now you have another wound in the mouth, and most patients don't want to have two areas of soreness as compared to one. So usually my two types of bone that I prefer in my practice is the allograft, and then almost the hybrid, which is the osteogen, especially for socket preservation. If we look at the different types of autogenous bone, a smart dentin grinder that uses the teeth is also considered an autogenous graft. It is actually the patient's own teeth. What you do essentially is grind the teeth. Well, actually, you're going to clean the teeth first of any decay or restorations or granulation tissue. You're going to grind and sort these teeth. Then you're going to cleanse these granules, rinse, and dry. So here's an example in this patient. We extracted the teeth, as you already saw. We leveled the bone, and now we're ready to place some type of graft. Well, we have a full arch of graft that we want to use. So why not use the teeth? There's no restorations in them. We're going to remove any decay or granulation tissue from these teeth. We're going to go ahead and put it in the smart dentin grinder. We're going to grind these up and then remove these particles. Place them into the sterile cleansing dish for defatting and dissolving any of the organic debris, bacteria, toxins of the particulate. And so the basic alcohol cleanser consists of sodium hydroxide and 30% alcohol, and we'll allow this to sit for about 10 minutes. So usually one of my assistants is helping me with the surgery. The other one starts to clean these teeth, grind them, and place them in the sodium hydroxide for 10 minutes so that I have this constantly moving and I have constant graft coming out. Well, the beauty is when you look at it on a scanning electron microscope, the particulate dentin, when the cleanser is added, is very clean, and all the bacteria tests revealed that there was no bacterial growth at this point. So the sodium hydroxide is very effective in removing any bacteria or toxins from this autogenous graft. Well, once the 10 minutes has passed and we've removed all the toxins and bacteria has been killed, then we know this particulate is going to be washed twice in sterile buffered saline solution. And so this way we're removing any of the sodium hydroxide from the graft material. So we'll rinse it twice and then blot any of the excess saline. And here we have a bacteria-free particulate autogenous tooth dentin graft to place into the sockets. And it didn't cost you a cent. Here we see the histology section of the cores taken from certain areas. And so there's a lot of studies that indicate that this dentin graft is very efficient and effective. In fact, there's several papers worldwide that talk about this. Well, here are some of the advantages of the Smart Dentin Grinder. We see fast bone healing of this autogenous graft. There's obviously going to be no rejection or inflammation or fast resorption. In other words, the enamel acts as like cortical bone, and then the dentin acts as cancellous bone. And so you have a variety of different rates of resorption and turnover. So you have a very nice stabilization and predictable bone remodeling. And obviously this reduced graft costs. When we look at the chambers, we're looking at slightly around $50, and I'm sure Kurt will talk about this at the end of the presentation. So here we see we've used the teeth as an autogenous dentin graft. At this point, we're going to suture and get primary closure. When we're only filling sockets, we don't need to use a membrane. If we've broken a buccal plate and there's what we call a 3-wall defect, and in that case, we definitely want to use a membrane. Here in the lower arch, we're going to be removing this bridge. We want a quick and effective way of removing this. So in this particular case, we use the WHAM key from GoldenDent. The way this works is you make a channel on the facial aspect at the height of the preparations, and you have a variety of different keys that are elliptical in shape. So when you place these into the channel and you rotate them up, that lifts the crown or the bridge work off the preparations. Excuse me. So here you can see that we remove the bridge restorations, further making the extractions of these teeth much simpler. Utilizing the physics forceps, we effectively remove all these teeth. And so our post-extraction steps here are to curette the areas out, irrigate the socket with sterile saline, squeeze the socket to compress the bone if there's any expansion. We'll rinse out any debris from the mouth. We'll place the graft material and membrane if needed into the sites. We'll suture the site, and then we'll have the patient bite down on gauze until we go over the instructions or deliver the immediate dentures. Some factors that may influence healing include infection, size of the wound, blood supply to the area, any foreign bodies that are remaining, readaptation of the flap, and then obviously the general health of the patient. With postoperative bleeding, we control that with pressure packs. Usually we'll give the patients 4x4s to bite down on. And obviously we don't want them talking and functioning or exercising for the next few hours or next couple days. Obviously we want them to take it easy. We definitely don't want them smoking of any sort, of course. Well, the areas that you're not going to be placing any graft, we recommend a hemostatic wound dressing. This is BioViva. BioViva is a great material that I use to control bleeding. When I extract wisdom teeth and we know we're not going to be grafting those areas, this works very well. These are individually packed, sterile, soluble, cellulose-based, bacteriostatic, hemostatic gauze dressing. And this is made from oxidized, regenerated cellulose derived from plants. So it's all natural. And it really helps create hemostasis in those areas where you may have some patients that are bleeding. It also helps prevent dry socket. So here we're going to deliver the immediate lower denture. We're going to check the bite, and then we're going to fill in those areas with soft reline with the mucoprin. This is a soft reline material from Kettenbach. It works very well. And then obviously after the extraction, we're going to go ahead and take a post-operative Panorex. This is confirming the areas that we place the grafting material. Notice that the dentin graft has some radiopacity to it because of the ground enamel in there as well. That works as the cortical chips and the scaffold for future bone. We usually cover these larger cases with antibiotic. Usually our first antibiotic of choice is amoxicillin, 875, 20 tabs BID. If they're allergic to that, then we'll follow the regimen of erythromycin or clindamycin. Any type of recommended analgesics are usually Motrin 800, Tylenol 3 if we expect any type of severe pain, or Norco 325. One thing I also recommend is dexamethasone. This is 4 milligrams. This is a bottle of about 100. Whenever I do a root canal, I usually give 4 milligrams of this before the root canal, and patients very rarely complain of any discomfort. The same goes with extractions. I'll usually give 4 milligrams of this before the surgery, and I found that there's very little postoperative inflammation. If we take a look at the before and after views of the Panorex, we can see we have completely removed all the teeth, all the infection, and we've grafted the areas nicely so that this patient now has an upper and lower immediate dentures. 9 weeks postoperatively, we do another trying of the final definitive restorations. And here we can see the final dentures that we were able to create. You can see aesthetically they look nice. These are the Veneris teeth, and the patient is very happy. Notice the midline has been corrected. The incisal edges follow her lip line, and we have some nice aesthetic teeth for her to smile with. Well, let's take a look at another case, and then we'll head on to the questions. This patient presented with severe decay like our last patient. So we're going to go through collecting the data, which involves her health questionnaire, any necessary x-rays and clinical findings, and then obviously we're going to capture our intraoral and extraoral photos. We're going to capture any models that are necessary as well as a bite, and then we're going to also acquire a CBCT because this patient is interested in possible overdentures. So this is the 4 images that we capture: the smile view, the intraoral retracted frontal view, and then the occlusal aspects of the maxillary and mandibular arches. We're going to identify any caries and crazed lines, broken teeth, bleeding on probing. And so if we look closely, we can see that every tooth in this patient's mouth has got severe decay and needs to be extracted. So these teeth look pretty hopeless to me. Unfortunately, this is still a very young patient, and we're starting to see this quite a bit in not only in the cities, but also in the suburbs, of these patients that use a lot of soda, sugary foods, processed foods, and sometimes we see the increase of the use of drug use like methamphetamines as well. So sooner or later, you may experience this in your practice where you see these patients presenting with gross decay extending to all their teeth. Here we can see some of the lower teeth. And when we look at the x-rays, we can see quite a bit of cervical decay that you may have not seen clinically. So here we can see a lot of these teeth, actually all these teeth, need to be extracted. We review the various options with this patient, and so this patient decided to go with some type of overdenture treatment because her mother had upper and lower dentures, and she knew from her mother that a lower denture was not the best solution, so she decided to go with some type of implant retained overdenture. In this particular case, we use the Panasil to take our preliminary impressions. Again, you can use the Silginot if you like, that works very well. You can see we captured the impressions with that. We also documented for the laboratory where they should put the new midline, since the midline of her existing teeth was slightly to the patient's right. Here we can see the workup from the laboratory, not only creating the immediate dentures, but also creating clear duplicates for further impressions for the definitive implant overdenture. So here we can see the restorations ready for the day of surgery. Well, since in the lower arch, our goal was to place 2 to 4 implants for an overdenture, we went ahead and designed a treatment plan with 3DDX to place 4 implants since this patient was so young. If we take a look, there were severe undercuts in the lower anterior ridge, so we knew in order to have at least 1 millimeter of bone on either side of the implant, our goal was to level some of this bone. So here we see a bone foundation guide, which also acts as a reduction guide for leveling bone. And then on top of that, we'll have a surgical guide so that we may place 4 implants for an overdenture. So this is what we call a stackable guide, where you have a foundation guide, and then once you've leveled that area of bone with a burr, then at that point you'll snap on the surgical guide for the placement of the implants. So if we separate them, it looks something like this. So day of surgery, we have the upper and lower immediate denture. We have our lower reduction guide as well as the surgical guide for the implants. We anesthetize the patient, and so we implement using the separators or the wedge as a pre-step to loosen the teeth and sever the PDL. And so here you can see how I'm going around each tooth with the separators. This is the bayonet size or shape, excuse me. We're putting this interproximally, where we'll put the 2 flat ones on the facial and lingual aspect. Once we've loosened the teeth, we can reflect a flap. This is the reflector. This is the paddle portion of the molt. This works very well in reflecting a full arch and degloving the mandible or removing the tissue from the maxillary arch. So I'll usually do that and then further loosen any remaining teeth. Here you see we're using the distal elevator, also from GoldenDent. Now, when I'm using the separators and the wedge or the distal elevator as a pre-step, notice I did that first, then I reflected a flap. Now I'm going to go back and utilize the physics forceps. What you'll find is that the enzyme builds up, and by the time you reflected a flap and get back to the teeth to remove them with the physics forceps, it's removed in half the amount of time because the enzymes have already built up in the periodontal ligament and these teeth are pretty loose. So following the long axis of the teeth with the beak of the physics forceps, we use a rotational force and start extracting these teeth. So here you can see we're taking multiple teeth out step by step. Even if they're multi-rooted, they're coming out in one piece because we're utilizing the physics forceps and removing them as atraumatic as possible. Well, since the posterior maxilla has type 3 to type 4 bone, we can also use the physics forceps to remove full molars out without having to section. Here you can see a 3-rooted molar has been removed without any of the roots breaking. So here we'll ready to level some bone. But first, our goal is to degranulate any of the sockets of any stubborn granulation tissue. So here you can see we're using the kit from GoldenDent. Once we remove that, we'll go ahead and use the bone leveling burr to just take the sharp tines out of the ridge. Now our goal is not to totally flatten this to where we have no retention of the denture, but to smooth it enough so where it doesn't upset the patient, even with a soft reline. Before we suture, our goal is to try the immediate denture before we graft. That way, if we have to smooth any more bone, we can easily do that. Here we see the immediate denture being tried in. So we see it fits nicely. So we can go ahead and now suture these areas after we've grafted. Well, as you saw, an autogenous graft is one way of going. Another way of going is using DBM material. This is a particulate graft putty available through GoldenDent. It works very well. And so you can use this to dispense right into the socket, as seen in this photo. And since we mainly just have sockets and we've reduced the ridge and have primary closure when we suture this, we don't need to use a membrane. Notice in the posterior section of the second molars, I don't really need to place graft because I'm never going to place implants that far back. However, we've placed some BioViva to control the bleeding, and you can see that in the number 2 and 15 areas. So here we can see the BioViva. We use chromic gut sutures to further suture this, and now we can go ahead and deliver the upper denture. At this point, we'll continue with the lower ridge. We've already anesthetized this patient. We'll utilize the separators to loosen these teeth as a pre-step for the physics forcep. We'll reflect a flap. By the time we've reflected a flap, these teeth have already probably gotten somewhat mobile. So using the physics forceps with that rotational direction, we'll start extracting the teeth one at a time in a very efficient and effective manner to where we've extracted the whole arch within just a couple minutes. At this point, we're going to go ahead and degranulate and remove any nasty tissue from the sockets. Once that's been accomplished, we'll place the bone reduction guide. So this is what our goal was, to snap it on. And at this point, we'll use the leveling burr with sterile irrigation to level this area. Here you can see it's been leveled and prepared to place the stackable surgical guide. Using the stackable surgical guide, we'll use the guided drill kit from OCO Biomedical. This is a great implant system to use because it gives you immediate fixation. So we'll use the sleeves to go ahead and drill, followed by the engaged dental implant. So here you can see we're using all 325 by 12 engaged dental implants from OCO Biomedical. The beauty of this implant is the proprietary bullnose auger tip that follows V threads that eventually transition to square threads and then micro threads, further giving it immediate fixation and stability. At this point, we'll place the tall healing caps on and place grafting in the areas of voids and smooth that transition or that step so it's a nice smooth ridge. We'll suture the area, deliver the lower immediate denture, and use our soft reliner material. Now in this particular case, I use a different system. This is the Tokiyama's Soft Reliner Tough. This is also another good type of soft reliner in addition to the Mucoprin that I've experienced in my practice. And so we utilize it in this particular case. On the post-operative x-ray, we can see the leveling that we accomplished. We see where the grafting was placed, and we see the implants are placed exactly as we planned them, thanks to the guided surgery. 9 weeks post-operatively, we see the areas healed very nicely. So we're going to go ahead and do a pickup impression. So we're going to rebase that as well as the bottom. And then the lower arch, you can see the locators have already been placed. They come in a variety of different lengths. And so I like to directly pick those up myself. So we're going to use the Tokiyama Rebase Fast to pick these up. So here you can see we've placed it in a monojet syringe. After these have been picked up with the black processing inserts, we'll replace them with the blue inserts, which create 1.5 pounds of retention per site. So this is 6 pounds of retention that this accomplishes utilizing these inserts with the locator abutments. Here upon healing, we see how nice the area is healed. And now the patient has an upper denture that has a nice seal and the lower denture that relies on 4 locator abutments for great retention. Well, this concludes our presentation for the evening. However, I do want to mention our Amplified Dental training courses, where at the University of Detroit we have live patient training so that you can actually work on live patients and utilize a lot of the instruments that you saw this evening, as well as a lot of the graft material that you saw this evening. And then also, I like to invite people to the Ascend Dental Academy for further implant training. So if you go to ascenddentalacademy.com, you can see some of the courses that we have. I like to have Dr. Levine take over, and I'm sure he's going to introduce Kurt Lawler from GoldenDent so that he can address some of these areas and talk about specials, and then we can also address some of the questions.
Well, you are correct. Thank you, by the way. That was an excellent presentation as always. I did want to take this opportunity to introduce Kurt Lawler. As I mentioned, GoldenDent has been a fantastic sponsor of these webinars. We get usually dozens of people commenting about how much they learned and how great they thought the presentation was. Kurt has always agreed to provide some type of special pricing, as well as talk about some of the educational opportunities that are available. So at this point, I'm going to turn the screen and the mic over to him. And Kurt, take it away.
Hey, I hope you can hear me. Lauren, you can hear me, right?
Yep, we hear you.
Okay, perfect. Thanks, Lauren. I appreciate it. And thanks, Ara. Another great presentation this evening. I'm just going to speak just for a couple of minutes here before we get into the Q&A session. I know a lot of our customers join our webinars on a regular basis, and we appreciate that. And for those of you that are new to GoldenDent and what we do, we're a Detroit-based dental company that operates under the principles of providing simple, predictable, and unconventional dental products. And our company started in 2007, but it relies on over 80 years of dental experience. We're still a family dental business of a third generational company relying on that past family dental knowledge to manufacture and market products that are unique and different. So if anybody is new this evening to GoldenDent, we appreciate your time. As a attendee for the webinar, like we do in a lot of past webinars, we always want to provide a promotional offer. If there's anything that was interesting that was discussed this evening that you might want to try to implement into your practice, or a technique, we always want to make sure that the webinars are worth your time, they're valuable, and that you also can take advantage of a promotional offer on any of our products that may have been mentioned this evening and are used by Dr. Nazarian in his practice. The promotional code is it's 15% off. I'll mention this before I go over just a couple more of the slides I have here for this evening. So it's a 15% off, and it's a flat 15. So it's just FLAP 15, and you can learn about our educational programs through amplifydental.com. And you can learn more about our product-based products that were discussed this evening, such as physics forceps or WAMKey or the bone grafting, at GoldenDent.com. So it is golden dash or a hyphen dent.com. And then obviously we're always available in the office if anybody has any questions to give us a call. We're more than happy to explain the products further and answer any questions you have. I'll put the slide back up here in a second. I just wanted to get through a couple more things here. The other thing is we do these specials for 24 hours. The 15% off is actually better than we even offer at any of the trade shows we attend on a monthly basis. So I encourage, if anybody is interested, to take a look at any of the products and visit our website or give us a call. And like I said, that expires tomorrow, the 8th, at the end of the day. So like I said, the physics forceps, this is what started what we do here at GoldenDent back in 2007 now. And this is the standard series set. So if anybody isn't already using our product that was on the webinar this evening, or maybe doing extractions in a different manner, or aren't 100% comfortable with the extraction technique they have, or it's not quite as predictable as they'd like, the standard series is always the best set to start with. It's the easiest to use. It's going to provide you the best leverage. And these 4 instruments will allow you to do second molar on the upper and lower arch. So you have 1 lower universal instrument, and then you're going to have 3 uppers: upper right, upper left, and an upper anterior. So sometimes if the patient has a smaller mouth or access, or you have, I guess, access restrictions, there is also the molar series. I don't think we showed this on the webinar this evening clinically, but this set is a set of 2 instruments that will go further back into the mouth and allow you to access erupted third molars. And they must be erupted. It's not, people ask sometimes if these work on wisdom teeth, and the answer is they can, but they really do need to be erupted, or you have to get some sort of engagement with the beak. And then secondly, they work well for hard to reach second molars. But like I said, if you don't have our product, I would always recommend starting with this set here, the standard series. You've got 90 days to try it in your own hands and make sure it's a right fit for you in your practice. And then usually people will look at these later on. This is, again, going to go further back in the mouth, and it's more of an accessory to the standard series set. The wedge, I'll just mention this quickly. This is an instrument that we worked with Dr. Nazarian on. He helped us design this, and it's something that he likes to use prior to the physics forceps just to ensure that it's a completely atraumatic extraction process. The physics forceps really is an elevator themselves. It's really not a forcep, but this is a good instrument to use in advance. You could also use what we call separators. We have available these instruments also on our site or through our company. They're not expensive. It looks like they're $74 each with the promotional offer this evening. We have a bayonet, a straight and a curved, and these are also good as a precept prior to using the physics forceps. Osteogen plugs. This is a very popular product for us. This is a great product to use if you want to get into grafting, or you're maybe looking for a grafting technique for certain cases that might be easier than having to deal with membranes. I know this evening we focus more on full arch cases where maybe the allograft or the autogenous smart dentin graft may make more sense in those cases, but this is a good product and alternative to consider. If anybody has not tried this product before, I definitely encourage you to take a look at it. It only works well when you have a four-wall defect and you just suture in place, place to dry, and you need no membrane. So this is going to be $42 a bullet, and makes it, I guess, $212 per box with the promo code this evening. It's something to take a look at. There's two sizes. The large is definitely going to be the most popular, and you can always obviously cut it to shape. Bone graft. So if you're using another allograft from another company, or you haven't used our Goldos brand before from GoldenDent, it really is an excellent allograft brand. It's what Dr. Nazarian uses in his practice. We've clinically tested it for a number of years and have had great results. The pricing's fair, and if we appreciate you giving us a chance to have your allograft business if you are currently purchasing allograft elsewhere. It looks like you can do a 0.5 this evening for $45 each, which is a pretty fair price on this product. And this is going to be, it's comparable to what people call like the 50-50 mineralized cortical cancellous mix allograft, which is a common one in the market. BioViva, this is, again, a great product that was demonstrated this evening. This is going to control bleeding. It works well maybe for socket sites that you're not going to graft. If you're currently using gel foam, this is something to take a look at. It'll definitely save you money. It's an affordable product, and it's also clinically really excellent. It's a hemostatic gauze, and as soon as it touches the tissue, it turns into like a gel, and it's easy to handle, and it works really well clinically. So that's called BioViva, and you can learn more about that again on our website. Two membranes. As was mentioned this evening, we like to have a long-lasting resorbable membranes. The membrane of choice that's our most popular, and I know what Dr. Nazarian prefers, is the EpiGuide. It's a large membrane, so if you're looking at it and you're looking at the pricing, it is 18 by 30, so I know it's often cut in half by our customers and made into two membranes. So just take a look at that if you're interested. It's a synthetic membrane, and it's long lasting, and it's fully resorbable. So it's a good choice for grafting, and it's easier to handle than some of the collotapes or other membranes on the market that might not stay around for as long as is necessary for the healing. Smart Dentin grinder. Again, this is an alternative to using an allograft or a xenograft. It's an autogenous method of making a graft from extracted teeth. There's various teeth you obviously cannot use. You cannot use endodontically treated teeth, and you have to remove, obviously, if there's a filling or crown or as much decay as possible. But we have on our website various articles and information on this. It is a really economical system to use, and clinically, it's really great. It's the the autogenous graft is said to be the gold standard for grafting. Your body is obviously going to be most adaptive to your own bone versus from another human or an animal source. So we've had good feedback with this. It's a great product, and again, there's a process to go through, and it may make sense for some offices if you're doing these full arch cases. And it's about $50 per use for this product. And again, you can learn more about that on our website. Reflector, this is just when you're going to go ahead and reflect an arch. It was just demonstrated here in the last case this evening by Dr. Nazarian. I think he went through that pretty clearly, but it has a very comfortable handle, and it provides a very effective way to reflect a flap. Our graft instrument kit, if anybody's looking for, whether it's a new curette or scissors, this is an inexpensive kit. I think it's like $400 or something like that with the promotional offering. It's a nice kit to keep together for your grafting, so you don't always have to be kind of looking for that specific instrument for the grafting that you need to do. You just keep it together and have this ready for your grafting procedures. If somebody's interested in looking at that, that's also on our website this evening. We also have more advanced instrumentation. We have some really nice snagless needle holders and some innovative scissors. These are hard to explain here just in a couple seconds, but there's some videos and some overview on these instruments that we call our Flex series. They're not your conventional scissors and needle holders. Each one has its own little unique aspect, like a lot of our other products. And there's videos and various things to explain those on our website. This is the burr kit. I think this was explained pretty well this evening. If anybody's interested in that, there's 6 burrs. You got 2 bone leveling burrs. You got a nice cutter, and then 2 shaping or degranulation burrs that are available here in this kit. Lastly, I'll mention this real quick, and then I'll turn it over to the Q&A. This is a little bit off topic for what we discussed this evening, but I thought it'd be a disservice to some of our customers that maybe haven't joined our webinar in the last couple months. This is a newer product for us since November. We've had really great clinical feedback on the product. It's been very popular for us, and it's been exciting to work with this new product. It's our new Wegotrix sectional matrix system. If you look at the pricing there, that pricing for $125 it's the price for the full kit. And there's some good videos and some more information on the website about this. But what's really unique about it is that we have a disposable ring. So you don't really care if the ring is very gross. This was a picture somebody had provided to us that this was a ring that was only 10 days old. And obviously, if you're putting that in a patient's mouth, it's obviously sometimes not the most attractive thing, or maybe it can be embarrassing looking. You don't care if you break your ring, if the ring's broken or tossed accidentally by your staff. You can modify the tie-ins for certain specific cases. But more importantly than the cost and the looks and the aesthetics of the ring, you're going to get that perfect separation force each and every time you use it. And that's really the great benefit, is you don't know if you're using, when you're using a metal or a nitide type ring, whether if you used it 50 times, 80 times, 100 times, you're not quite always sure unless you're putting on a gauge that you're getting that perfect tight contacts that you need when you're using a sectional matrix system. So it really has a lot of different benefits. The anatomical wedges are great. The wedges are good. They're very adaptive. They're going to give you that wave type shape with the wedges based on the design of them. And again, if you're using a different brand or a Tuffelmeyer system, this might be a good way to get involved in a sectional matrix system for $125. You really can't go wrong. It's the price of a lot of other people's rings. WegoFill, this is a product we've worked on with Dr. Nazarian over the last year or so. It's a zirconium infused composite. Again, I just wanted to mention this quickly. It's off topic this evening, but this is a really great posterior composite if you're looking to find a composite that maybe might work a little bit better for you and provide a minimal shrinkage, low wear. It's radio opaque. You'll see some clinical cases and maybe some past videos on our website or our YouTube page that shows Dr. Nazarian using this product. I know he's had really great feedback about it. If anybody has any questions, they can ask him here in a second in the Q&A session about WegoFill if they want, even though it's off topic. And lastly, Amplify Dental. So this is our educational program. Dr. Nazarian leads these programs. He does the lecturing and the clinical portion. I'll just go through a couple quick past course photos. We do extraction, grafting, and an immediate denture program. I think we have one coming up. It looks like May 17th and 18th is our denture program. It's going to be more in line with kind of what we discussed this evening, but obviously much more comprehensive. We'll be focusing more on full arch cases, planning for immediate dentures, and you actually get to do all this, what you saw this evening, on live patients. So it's actually quite special. We'll do full arch flap, extraction, graft, bone leveling. You learn everything day one, again, in a lecture, in a comprehensive lecture with models and hands-on portion. And then day two, it's live patient. And it doesn't matter if you're not licensed here in Michigan. This is our teaching facility. You just have to have a license in, obviously, the United States or Canada. And you have your own operatory. We have you work with a partner. It's a great facility. This is Dr. Nazarian doing a demonstration where maybe you wanted to show somebody a specific technique prior to the breakout session, or sometimes during the day, people will ask about a certain procedure. And again, it's all live patients. So we'll see, anywhere from 65 to 100 plus patients during the day with 15 to 25 doctors. So it's a great program. You can learn more about it at amplifydental.com. And I think our June one sold out, but I think May 17th and 18th, which is coming up, we have a couple more seats open. And I guess that's it for me. I'll leave this up and turn it over to Lauren for the Q&A. And I appreciate everybody's time this evening. And hopefully you'll join us again for our next webinar in June.
Thank you, Kurt. Ari, you got time for some questions?
Absolutely.
As I had mentioned initially, we're probably not going to get to all of them, and we'll do our best because I do see some of them are kind of asking the same thing, so I'll do my best to consolidate some. Okay, this was actually some questions that we got from the registration. If a patient has severe bone loss over 60 to 70% and active infection, will you extract the teeth and let the area heal before you do any bone grafting or placement of implants?
Yeah, definitely. I mean, if they have that much infection present, then I'd rather do it as a two-stage surgery, remove the infected teeth and level the bone, and then come back and graft at a later time. Implants, unfortunately, are not forgiving to infection.
Right. Now, for that patient who's had bone loss in the past, if you do place implants, is there some concern about peri-implantitis and bone loss if they have that history of the bone loss?
I think, when you're placing implants, if the patient lost their teeth at an early age, then if they don't change their habits and change some of the things that they may be doing that caused the bone loss or the periodontal disease, then they may be doomed to repeat that again. So they have to change their habits, obviously. Now, when we're doing the type of leveling that we did in the last case, then we're placing those implants into an area of healthy bone. We were apical to the areas of where the roots were. So I wasn't so concerned at the placement at that time. But again, we want the patients to protect their investment as well.
Sure. How do you determine the type of prosthesis a patient can have before the extractions? And if a patient desires a fixed prosthesis, can it be done at the same time the extractions are done, or the grafting should be done irrespective of the prosthesis?
So the first thing we want to talk to with the patient is to see what their goals are. If their interest is in implants, but they're like, there's no way that this can fit into my budget, then we'll start talking about overdenture options with that patient. An overdenture is much easier to plan for because the denture covers the implant, so you don't see the emergence profile of where the implant is. So when placing implants for an overdenture, it's not as big of a concern, the position of the implants, even though you still want a good anterior-posterior spread. However, if they plan on doing fixed, then obviously we're going to plan it with the CBCT. And yes, we can place the implants at the same time and have patients walk out with fixed bridges. Now, we didn't cover a case like that, but this is something that we go into in great detail at the Ascend Dental Academy. But we still follow the same protocol as you saw this evening. We would just follow it with immediate implant placement, multi-unit abutments, and then a fixed provisional restoration.
Got it. Considering that some insurance companies don't approve bone grafts, how does that conversation go with the patient, and what's a reasonable price to be charging a patient for a graft?
I think if you present to these patients and indicate the value of what they're going to get that insurance may not cover, the patients will accept treatment. When we look at people spending money on an iPhone a big screen TV, a trip, or a vacation. Insurance doesn't cover it, yet patients find a way to pay for it. And I think the same is true with dental care. If patients feel they need it, the insurance is great and supplementary or complementary. In other words, it complements a little bit of the what they're going to be paying, but it's not going to take care of the whole amount. And patients, I think, understand that. So I think we as providers have to present it in such a way that we understand that insurance may not cover the whole thing. It's great to have insurance, and let's utilize what we can, but it may not cover the whole bill. And so for that reason, we offer a variety of different dental payment plans. Alphion's one. People may be aware of Care Credit or Lending Club are some of the other ones that are available for the patients.
Yep. I have a few questions here about anesthetic protocol. For these larger cases, where are you injecting? Are you doing blocks? Are you doing PDL? How do you typically anesthetize these patients?
So in the upper arch, usually I'm doing infiltration on the facial aspect of the ridge, but then I'm also giving like palatal and incisive um, uh, blocks or infiltration, if you want to call it. In the lower arch, we're doing mandibular blocks. If I'm doing a full arch, usually I'm starting with the top. I'm not anesthetizing the upper and lower at the same time because number one, I'd probably be giving too much anesthetic, number one. Number two, by the time I get to the lower, they may be unnumb. So I usually will start at an arch at a time, finish that arch, and then re-anesthetize when I'm ready to move to the other arch.
Sure. What's the risk factors for immediate implant placement versus just waiting to, put some bone graft in there and go back after it's healed?
Well, the risk factors are going to be slightly higher when you're placing implants at the same time. However, case acceptance is going to be higher when you do implants at the same time. In other words, let's say I told you you needed all your teeth out and you need to wait 8 months before we give you a fixed temporary, or I need to take your teeth out and I can give you a fixed temp the day that I take your teeth out. You probably would accept the second option of getting the implants with a fixed provisional. This is why we see a variety of different dental offices like Clear Choice popping up across America and a lot of other different varieties of Clear Choice, so to speak, where people are doing this because patients don't want to wait 8 months to get their final restoration. If they can get it in 4 months and walk out with a fixed temporary teeth in a day or same day, then they rather do that. And they understand that there may be a little bit of a higher risk, but I'd rather have a little bit of a higher risk than walk out with no teeth.
Sure. With the physics forceps, if someone is seeing trauma, pressure on the facial and the buccal tissues, is that typically a technique issue that they should be working on?
Yeah, definitely. So if you see bruising on the facial aspect, then the dental provider was probably squeezing too much and not pivoting along the bumper. Instead, they were just squeezing it. And so what they did is crush the blood vessels in that gingival tissue there. So yeah, that is not common to see bruising. You saw we took a whole arch of teeth out and you didn't see any bruising on the facial aspect in the upper or lower arch. So it's definitely a technique thing. I would say the majority of the doctors that come to the course are either A, doctors who have never used the physics forcep, or B, we get a handful of doctors who ordered the physics forcep, but they're just really not comfortable implementing it just based on seeing some YouTube videos. So they want to further enhance their technique. And so we see those doctors as well. As Kurt indicated, having the availability of doing live patient care here in the United States in a dental school is invaluable. I mean, it's unbelievable what we accomplish. And we've actually done, I think, up to almost $3 million of extractions worth of donations to the patients over the years by, providing this service for people that can't afford this type of treatment that need extractions.
Yeah.
So it's a win-win for everybody.
Yep. For the dexamethasone, are you having the patients fill out the prescription prior to the appointment, or are you providing that at the appointment? And what are the health contraindications for it?
Yeah, so when we do a full arch reconstruction or we're doing extractions of any sort, these are IV sedation patients. So they're getting a medical clearance from their doctor ahead of time. And when we monitor them for the IV sedation, we have a pulse oximeter, an EKG, and a blood pressure cuff. And we also have a CO2 output. And so we're regulating all these things, but we have their prescriptions filled a week prior to their IV sedation appointment. This way they have all their medications ready, and we actually have them start with the antibiotic 3 days prior to the surgical date. So if we have them on amoxicillin 875 BID for 10 days, the first 3 days are actually before the surgery, and then 7 days after the surgery. So the dexamethasone, we have that within our office, so we'll dispense that to the patient. But all the other medications, like the pain medications or the antibiotic, are already prescribed to the patient a week before, so that these are filled so that they can start using some of the antibiotics. And then we also have them start rinsing with the Paradex a week before as well to lower the bacterial count.
What was the Bluetooth system you were using to upload photos?
The camera system I have is from Lesterdyne. So the Pentex, I think it's the ISD 500 that I have, has the Bluetooth in it, and then the monitors in the room have it. The Advantage technology people or whatever had set it up for my camera, so I'm not really familiar how it does it, but it does it with the software that I got through Lesterdyne.
Okay. I guess it's a question more for Kurt. What's the cost of a standard series of physics forceps?
The price is actually, it's been the same since 2007. It's $15.85 for the 4. So if I've done my math right, that's, like they are several $100s each an instrument, and that's why we want to make sure people are comfortable with the product, and that's why they have 90 days to try them out. So usually people that like them, obviously, they're worth it to them 10 times over. If they have the ability to do extractions more efficiently or not as refer as much, and if somebody for some reason struggles with them, it's usually when they get back less than a 1% the last 10 years, then it is what it is. We'll get them back. So there's never a risk of trying the product. But you'll see all the pricing on the website, but it's $15.85, and I think the discount, it probably makes it I guess what does it make it? I don't know, like $1,200-$1,300, something like that.
Okay, I want to get to at least one or two more questions before we're done here. Does the EpiGuide membrane require primary closure?
No, it does not. The EpiGuide is a synthetic membrane. It's side specific, so the smooth side goes to bone and the rough side goes to the gingival tissue, and you don't have to have primary closure. It takes about 6 to 8 weeks to dissolve, and by that time the area has been already covered with the epithelial tissue and soft tissue. It's a great membrane, and by the way, it doesn't have this nasty smell to it. I used to be a big advocate of pericardium, which was very nice, but if it was exposed, it had this funky smell, where EpiGuide does not have any type of odor because it's synthetic. It works very well.
Good to know. Final question. After delivering the immediate denture, are you rebasing the same denture or making a brand new one after 9 weeks?
In some cases, I may rebase it if we got the teeth estimated very correctly. If they don't like the teeth that are in their immediate denture, then we'll go ahead and start with a new set. So in the first case, you saw The upper set, she wanted the teeth a little bit more flared, so we went ahead and just remade a new upper set. And the second case, we actually just rebased the original immediate dentures. For my immediate dentures, I always go with a high-end tooth, and this way, if we got it the first try, we just rebase it and we're done.
Got it. Well, we're at the bottom of the hour, so Ara, you want some closing comments before we wrap it up?
Well, I want to take this opportunity to thank you, Dr. Levine. You always host a great event, and I always like watching all the other webinars that you put on, so we appreciate that.
Thank you.
Kurt, thank you from GoldenDent for having me speak on the topic that I love, which is extractions, grafting, and implants. I look forward to meeting everyone at one of the courses, either at Amplify Dental or at Ascend Dental Academy. And again, thank you for giving me this opportunity, and I wish everyone a great summer.
Well, thank you. I wanted to thank Dr. Nazarian for the fantastic information. I've had the pleasure of hosting probably close to a dozen webinars with him over the last few years, and I stay tuned because this is not like some speakers who just regurgitate the same material over and over for decades. Every time I'm seeing new cases and new ways of looking at things, and it's always fresh and interesting. And so I thank you for putting the time and effort into this. As I mentioned at the beginning, thanks to Kurt and for GoldenDent for their sponsorship. It's not easy to put together these webinars. The invitations have to go out. We put it on Facebook and Dental Town and all over the place, and that's why we get over 1,000 people registered. We do these webinars on a regular basis. Please look forward for further invitations. Also consider taking advantage of the very generous offer that Kurt offered. The FLAP15 is your code for 15% off. I can't think of any of our clients who've ever returned anything they've ever gotten from GoldenDent, but they stand by their products 100%. I will continue to provide webinars for them and work with them because I believe very strongly in the company and the products that they offer, and I would highly recommend you take advantage of that offer. We thank all of you for your time because we know how valuable it is, and we look forward to seeing all of you on future webinars. Good night, everyone.